Welcome to Module 9, the Care Transfer. This is the 9th of 10 modules in the course. By the end of this module, you will be able to describe characteristics of adult health care to patients and families, create a practice transition policy, identify care transfer activities for the transition plan, and transfer care in a supportive manner. Adjusting to the differences between children's and adults' medical care is a major challenge for both patients and caregivers. Recall the 8 steps of the transition process, supported by the Joint Statement on Transition, the 6 core elements, and the Florida algorithm. The final steps in this process focus on the successful movement to new adult-oriented providers, to adulthood, and to a new healthcare system. The term culture shock describes the discomfort experienced when moving to a very different environment. For example, a rural village to a large city or a new country. It is normal to feel uncomfortable in a new, strange environment where old ways of doing things may not work. The care transfer is akin to culture shock. Prepare the patient for some confusion and discomfort while emphasizing their ability to learn new customs and language. As discussed in Module 2, pediatric care uses the shared management model. In this family-oriented model, caregivers are the experts in the child's chronic condition. Adult medicine regards the patient as autonomous. Providers do not view the patient or the family as an expert in their own health condition. During medical visits, patients are seen alone. Practice staff members expect them to make decisions and function independently. Pediatrics uses a developmental orientation with a focus on assisting children to acquire new skills over time. Providers often use a supportive approach to families and patients, which is non-judgmental. Internists might describe this as a maternal or paternal approach. Staff members tend to be warm, optimistic, and interpersonally oriented. This approach accommodates the family's competing priorities, school obligations, extracurricular activities, siblings' needs, parents' work responsibilities, and so forth. Adult medicine focuses on the diagnosis or the disease rather than on the whole person. Adult medicine uses a specialist consultation model. Providers share findings and recommendations in a written format more frequently than by phone or in a face-to-face conversation. Adult medicine facilities are much more businesslike and formal. The approach is less accommodating to the preferences and priorities of the patient. Pediatric providers rely on parents' and caregivers' observations about the child's development, changes in their health status, response to medications, and so forth. The provider is responsible for active advocacy and oversight. Children with complex medical conditions often receive care through condition-specific clinics. Adult-oriented providers conduct tests or procedures to diagnose a new condition. They rely less on the observations of the patient or caregiver, especially with new patients. Patients, rather than providers, have primary responsibility for oversight and self-advocacy, such as requesting that a specialist provide test results to the PCP. Primary care providers typically refer patients with complex needs to multiple specialists. The patient sees these providers sequentially over time on different days and in different locations. Condition-specific clinics are uncommon. Pediatric practices have an established multidisciplinary model with easily accessible care coordination, services, and supports. Nurses and other staff provide medical care and psychosocial support. Staff roles and responsibilities are more differentiated in adult medicine. Nurses and other staff address only medical issues. They refer to social work for non-medical needs or for psychosocial support. It is also important to note that care coordination, supports, and services are less accessible in adult medicine. Despite the barriers, the transfer remains crucial for continuous, accessible medical care. Many children's hospitals and facilities also have policies regarding the maximum age of patients. For example, Nemours Children's Clinics cannot serve individuals over the age of 21. Insurance reimbursement, professional guidelines, and licensure laws may also require a care transfer between the ages of 18 and 22. Many patients and parents see the transfer as a loss. This is especially true for patients with complex conditions. Over the years, you may have provided a life-altering diagnosis, emergency care, referrals for an important surgery, or a new treatment. Has this happened to your patients? If so, how have you found out about these policies? From the hospital? When insurance has denied a claim? Or from the patient after such a transfer? Take a moment to consider these questions. The presentation will automatically resume in 1 minute. In the current state, transition outcomes commonly fall into one of the following categories: everything stays the same, mixed transition, full transition, and dropping out. Some patients learn about transition on what becomes their last visit. This type of abrupt discharge and transfer frequently leads to an interruption in care. The next slide presents a video clip.
Yeah, at the age of 18, Dr. Shapiro offered me, shall I say, another alternative. Instead of seeing him, I could see somebody that deals with older patients. I chose to stay with Dr. Shapiro because he has seen me basically since I was born. I mean, he knows me better than any other doctor. And I personally didn't and continue not to feel comfortable going to somebody who, in a sense, has to learn my case report all over again. I mean, I've always felt very comfortable with Dr. Shapiro. I know he makes very competent decisions regarding my care, and I will continue going to him for the foreseeable future.
Can you think of any reason why you might ultimately transition from Dr. Shapiro?
At this point, I really can't see any reason not to continue seeing Dr. Shapiro. Obviously, if something were to happen to him, then yes, I'd have to. But Boston is certainly a reasonable trip for me to make, and if it means that I'm getting the best quality care, which I believe I get at Children's, then I will continue going there.
What is it like as an adult going to Boston Children's? Do you have thoughts or feelings, or do you have a sense that you're an adult in a children's hospital?
To be honest, I never really thought about what it's like being an adult at Children's. I mean, I go there, I see Dr. Shapiro, I leave, whatever. Because I think a lot of that has to do with the fact that I had all of my surgeries there and I was always there. That it just always felt natural going there. So, in a sense, I think it would almost feel different going somewhere else and seeing somebody else. Especially in regards directly to my disability.
Good transition planning is the best way to preempt or address barriers associated with a care transfer. Many pediatric practices write a practice transition policy that proactively outlines the transition process. Such policies support transition and avoid interruptions in care. Write a practice transition policy that describes your process with key ages and stages. Provide the transition policy to all patients at age 12 when you begin transition discussions. It is important for all concerned to recognize that it will take time to establish new roles and relationships. There are rare instances where transfer to adult medicine is not in the best interest of the patient. These sample practice transition policies from the National Center for Healthcare Transition Improvement and from the Center for Medical Home Implementation are two examples. Examples include the age patients begin transition preparation, healthcare transition process and activities, age or age range for care transfer, Special information for youth with special healthcare needs. Families tend to forget how things went when they started with their current providers. This is understandable, since some children have been receiving care from their pediatricians for 15 years or more. Just as they learn to negotiate the pediatric healthcare system, they will also develop the new knowledge, skills, and experience for the adult healthcare system. Talking about these past experiences may help youth and families appreciate that building trust and respect takes time. Include conversations about adult medicine and the care transfer in transition plans. Begin age-appropriate activities in middle adolescence. Discuss the fields of primary and specialty medicine with the patient. Clarify the provider's field, especially when making multiple referrals. Build the patient's confidence in the new provider by sharing what you know about the doctor. Do you know them personally? Do you respect them as a physician? Do they have experience managing chronic or complex conditions? Do they see young adults, the elderly, all of the above? Include specific items for youth with special healthcare needs based on the patient's transition plan and the new provider's familiarity with the condition. Prepare the patient for care oversight by making initial contact with the new provider's office and doing research before the first appointment. Patients should make a list of questions for the initial visit. Let the patient know that it is okay to find a new provider if the first referral is not a good fit. Dropping out of care is not the next option. The 6 core elements and related tools provide guidance for the care transfer. The next slide presents a video clip.
One thing is how to explain the disability in layman's terms. I actually had to research it myself a little bit when I started to get interested in it. My mom kind of, because I lived a life of quote-unquote normality for so long, and I'm like, what's this kind of surgery? What happened here? She doesn't remember. So something like asking the doctor to explain it to me in layman's terms or something. And now that is my responsibility to ask, but when you're younger, even when you're 5 or 6, if the doctor can explain, this is what's going on, then you're more likely to understand what your disability is when you get older.
This section provides strategies to prepare the patient for the transfer and for saying goodbye. During the transfer, the patient is the decision maker with full responsibility for oversight and self-advocacy. Remind the parent or caregiver of the shared management model and clarify their role during the transfer. The path to independence, first discussed earlier in the course, remains a useful tool throughout this transition stage. The care transfer includes a psychological component. Practice staff members must say goodbye and may feel an emotional loss. The patient also needs to say goodbye. Look at other fields such as hospital-based care, psychology, or education to develop a termination process that acknowledges this change in a positive way. There are a number of strategies to ensure that caring relationships will end well and to encourage effective working relationships with new providers. For youth with special healthcare needs, consider a transition event or a final meeting with the patient and family that denotes a change in status and provides a psychological sense of completeness of one phase of their life. Before closing this module, let's look at resources for your practice and key points. The ultimate goal of transition preparation is a smooth transfer to adult medicine that provides continuous and accessible care for the patient. Use the links from this course's toolkit to access the resources from this module. The next module demonstrates strategies to implement course material in your practice. You can pause here for a break or continue automatically into the next presentation.